Welcome to TraumaCast. It's like a podcast, but about trauma. Listen and learn from our team about current trends, new research, and continuing performance improvement efforts. This education is eligible for CNEs. Successful completion includes watching or listening to the entire session and completion of the attestation and evaluation. The link for the evaluation and attestation is located at the end of this video. We hope you enjoy. Please let us know what you think. Well, welcome back to TraumaCast episode number 4. We haven't had a TraumaCast in a little bit, so we decided that we would do this TraumaCast based off of who works in the trauma department and what they do. I'm pretty sure that most of our bedside nursing knows a couple of us, and obviously our trauma and burn nurse practitioners, but we'd like to introduce you to all of the different parts of the trauma team. So you guys know me, I'm Cindy, I'm the Injury Prevention Education and Outreach Coordinator, and of course we always have Jen and Liz, and we have a special guest today, and that's Margaret, and we're going to introduce you to her and what her role is on the team in just a couple of minutes. But before we do that, Jen and Liz, why don't you tell us what you do in trauma?
Okay, so my role, I think folks may know me as a trauma burn nurse practitioner, but several years ago I transitioned and took on the role as the PI coordinator. So what does that mean? That means strong focus on program quality and safety and patient review. So it's kind of a nice mix to clinical practice. It's a great focus. So yes, my current role is the trauma and burn PI coordinator.
And Liz, what's your favorite part about your role?
Favorite part about the role is really seeing initiatives come together and really seeing things like door to blood times coming down. I guess it just, and working with the quilt program, honestly, like a lot of the hospital wide QI work is really neat. So
And
yeah,
what is
anything that
quilt? I don't think that a lot of people, unless they're
yeah.
involved in quilt, like when I
Oh
first heard about quilt, I thought it was like stitching.
yeah, absolutely. So this is it's a training session that happens twice a year. It stands for the Quality Improvement and Leadership Training, and it basically folks in the hospital apply to the program with the ideas of a PI project, and they are really taught the nuts and bolts of PI. And at the end of the training session, present their findings. So it's a really nice way to learn QI methodology.
Can anybody be a part of quilt?
I think anyone can apply. Yeah, it's terrific.
Cool. All right, Jen, who are you? What do you do? Tell us about you.
Well, I am the Trauma and Burn Program Manager. I've been in this role now for 13 years, I think. And so I kind
As a
of
teenager.
I know I kind of do the big picture of the Trauma and Burn Program. I always describe my role as I oversee different arms of our division. The arm that most people are familiar with is the clinical arm. And the clinical arm is the care that we deliver to trauma and burn injured children every day. It encompasses our nurse practitioners, our surgeons, residents, and nursing teams that are all involved in this patient care. And in that clinical arm, Liz's role as PI coordinator sits, and pieces of Cindy's role sit in there. And we really do look at every single patient that comes through as a burn or a trauma patient to see if there's things we can do better. And it's not just looking for mistakes, it's looking at things we do well and seeing, is there more efficient ways to get it done? Or is there new literature that makes us do this better, or a different way that has been shown to improve outcomes? A lot of our time is spent on this. If you go to any of our quality meetings, this is usually what we're talking about. We do things like look at individual metrics. We look at trending metrics to see, okay, well, this child didn't get intubated within the 7-minute window. What happened, and how does that sit with the rest of the children who got intubated, and how quickly? We do that for things like time to intubation, time to blood. Do we follow the guidelines that we have set. And we put a lot of that out there in our trauma app as far as a clinical resource for our clinical team to uh, be able to use in order to improve our care. But there's also a couple other arms to our team. We do definitely have our injury prevention and outreach arm, which Cindy is not really an NM1. We do help her. She's the one with the title, but I do think she gets support not only from inside our division, but she definitely has partners within the hospital that she works with in order to bring that injury prevention to the community and to also reach out to those adult centers that are sending us their patients. The another arm we have is we have a very strong research arm. I don't know if people are aware, but Dr. Bird is a very experienced senior researcher. He has, over the years, has gotten millions and millions of dollars in grant funding. And our research team, we have 2 research assistants. Well, 2.5. One just went PRN, and we have a full-time research fellow who's a surgery resident who takes a break from clinical time to come do research. That team works with Dr. Bird, and his goal is to look at care delivered in the code room to decrease errors. And so a lot of really cool stuff has been done, and there's a lot of publications that you can look up that Dr. Bird and his team are involved in. And Cindy, Liz, and myself have been fortunate enough to be able to work within his research team and with his research team on some of these initiatives. We also have a registry. I think as I've done education through the years for nursing, I try to really push my registry team and not so much who they are, but what they do. They look at charts of patients that we've taken care of in the trauma world, and they abstract about 200 to 250 different data elements. So if you ever wondered, does your chart make a difference? Does anybody read it? Yes. First of all, the trauma clinical team reads it, and our registrars read it, and they are taking things like first blood pressure, interventions that are done on the floor in the ICU, OR visits, time in the OR, time in imaging, and they're really putting all those data points, and that can be used not only to pull data to look at how our patients are doing and their outcomes, but it's also used to go into the National Trauma Registry, in which we can get reports that compare our trauma center and our outcomes with other children's hospitals in the country. So with that, I kind of, like I said, I kind of oversee the big picture stuff, and I help in different arms as I'm needed. So kind of I consider myself a generalist in trauma. How's that?
That's a lot.
It sounds like it. It's not.
So, Margaret, before we introduce your role, because your role is new for the trauma service, um, and you've been with us for what, maybe 4 weeks, 5 weeks?
Yes, I've been in this position for the past a little over a month.
Okay. Before you were in this position, did you know all of the things that our team did?
No.
Right?
Absolutely. I've learned a couple things right now. I've been a part of children since 2014. And I feel like I'm learning new things every day of like more about what happens behind like the direct patient bedside experience. And to see the amount of work that goes into research, into project improvement has just been incredible. I'm meeting so many new faces and learning of so many new projects every day.
Um, Jen, one of the things that I think is kind of like a misnomer about our department is everybody thinks that we're included in the emergency department, and it's confusing to some people. So, can you explain a little bit of the structure of like the ED versus trauma and how we collaborate, but we are a bit different?
Yes. Well, first of all, I think there's 2 reasons I think people think we're part of the emergency department. The first is our emergency department is called the Emergency Medical and Trauma Center. So trauma is actually in the name of our ER. So that's one misnomer. And I think the other misnomer is because our office is located very close to the emergency room. Now, it's very secret in where we live. We don't share that. So if you know, um, and so I think those 2 things get people confused. But emergency medicine is taking care of the medical patient in addition to injured children, where the trauma department really focuses on the injured patient and only the injured patient.
Yeah, I think that's helpful because a lot of people do get confused. They're like, "Oh, you work in the ER?" And I'm like, "Well, no, not really. I work adjacent to the ER. I'm like ER adjacent."
And I think the other thing is people think when you talk trauma, people talk about trauma centers. And most people, the minute you say trauma center, thinks of just care in the code room, care, that emergency care. And what they don't understand is that a trauma patient has very trauma related um, care, complications, considerations that go not only from the emergency department, but follow that patient throughout their whole trajectory through the healthcare system until they're ready to go home or to rehab. And those are things that, as part of our PI process and what we're looking at with patients is we're not only looking at them in the code room, we keep an eye and we're watching those patients for complications and other trauma related focus areas throughout their whole stay.
Even what happened before they even arrived at the hospital, right, Cindy?
Yeah, definitely. Definitely, because it doesn't start, the care doesn't start when they come into the emergency department. The care starts right after the injury happens and, what the parents or the family does first, who do they call? Do they call their pediatrician? Do they take them to an outside hospital? Do they call 911? There's a lot of stuff that happens before a patient even gets to our doors that we also follow like every single step of the way from injury into until they're healed from whatever injury it may be. Okay, so I think we have done enough introductions and I'm very excited to introduce Margaret and as our new care coordinator. Is that the right title?
That is the title.
Okay,
That's what we're
so
going with.
Margaret, tell me what a care coordinator does. Oh,
A
wait,
care
before you do that,
Mhm.
tell me a little bit about you. How long have you been at Children's? What did you do before you joined the secret office that everybody thinks is a closet?
Which I just learned about with this job, so still so like I said earlier, I've been a part of Children's for quite a while. I started the summer after my freshman year of nursing school as a direct observer. So I did that for 2 years. And when I graduated, of course, I went to the unit, the only unit that I was not a direct observer on, which was surgical care. Was a bedside nurse there for a couple years, and then I was been a shift coordinator for the past 3 years. And then over a month ago, I came over to the trauma burn department. So yeah, been here for quite a while. Have gotten to know a lot of people throughout the hospital, and I'm so excited to be focusing on trauma.
Okay, and Margaret isn't just hired to be like the trauma care coordinator, she's trauma and burn, but today we're going to focus on trauma. So what does a care coordinator do? Because this is new. This is new to me and Jen and Liz. Like we're all like, what is the care coordinator and what do you do?
Now,
Yeah,
before
so
Margaret answers
Mhm.
that, hold on. I want to clarify that everything she says, because this is a new position, we're still figuring a lot of it out.
So this isn't my contract. It could be changing.
What are you doing
So
now?
it's an evolving position.
Right.
So a large part of it is coordinating care from inside the hospital to outside the hospital. So I kind of like to break up my days versus like what's happening on the inpatient side of things. I'm getting to know the families, getting to know the patients. Coming from the surgical care unit, I'm very familiar with that patient population. I'm familiar with the nurses who work there, the techs. So it's been really nice to touch base with their caregivers, any patients' caregivers, and be a resource. So if they need help with cervical collars, wound care, that kind of stuff, I'm here as hands-on help. I can come to the bedside. I can help out there. In that process, I'm getting to know the family. So that kind of jumps into the outpatient side of things in terms of helping arrange appointments or identifying any complications. I work with a couple other people as part of a psychosocial support team. So there's Carrie Tully, the psychologist, Marie Rizzo, the social worker, Steph Schreider, the occupational therapist, Joe Sanchez, nurse practitioner, and did I say Marie Rizzo,
You
social
did.
Kate,
worker?
You started with
And
her.
Kate D'Onofrio, child life. So we're all we all make up the psychosocial support team as part of a care coordinator, I'm doing a lot of the initial assessments, like the trauma mental health assessments that tell us what patients and families we need to pay particular care with in terms of maybe they need a little extra social work help or a little extra psychology help. Um, so really just taking all these different pieces of the trauma team and trying to kind of streamline it into what we can best do for these particular families.
What's the name of the screen? And do you do it with the parents or do you do it with the patients or both?
So it's the trauma mental health assessment. We just started doing it. So I've only done it for one family so far. It's still in the
Okay.
works. But for children who it's we initially give it to the parents, excuse me. We give it to the parents and it focuses a lot on their reaction to the injury, if they were there when it happened, if they have past trauma, how they've been doing since the incident. But if the child is appropriate and old enough, the questions also go to them as well. How they've been doing with the incident. Are they having nightmares? Are they startling more frequently? Um, how much this has changed their living. We use different scales, so kids get flagged on different bases to kind of let us know who needs an extra referral or two.
What are they flagged because of the screen?
They're flagged because of the screen. So
Okay.
this screen is set up where, depending on the age, depending on one assessment may need lead to another assessment if we need to go deeper into one area versus another.
Do you do the screening with the kids when the parents are in the room or do you do it separately?
The idea is to do it separately. Again, it's just started, so I've only had the opportunity to perform it with one family. Um, with this child, the questions didn't pertain to them. It was just for the family. So the parents took themselves through the survey. We have an iPad that I'll give to the family. I'll be there for questions if they have any, but we found that people tend to answer more honestly or more liberally when it's a little more private. So just depending on the family, I'm able to adjust the assessment in a ton of different ways.
Do you give the kids the iPad too, or is the plan to give the kids the iPad, or do you just have a conversation with them?
I think conversation with the kids.
Okay.
Maybe if they're a bit older, if they're like an older teenager who maybe had no interest in talking to me, I could see giving them the iPad. But I'm hoping that with being so present during their inpatient stay at the bedside, that I can build a really good rapport with them and be able to have those conversations.
And what are the goals of doing these assessment? Like, is the goal to do it on every inpatient trauma patient, or
hmm
is it only with specific injuries?
So goal is to do it on every inpatient trauma patient, um, to help anybody from slipping through the cracks. We have so many consults, so many uh, people coming in, PT, OT, nutrition, speech, just so many different people that if I can be the person who kind of like sits at the center of it and it's like, okay, we really need to make sure they see social work. We really need to make sure they see a psychologist. That can happen either while they're inpatient or even as an outpatient referral. So we don't want to hold anything up in terms of discharge if they're clinically ready to go. But we want to make sure they're not lost from the system and that we're continuing to provide care after they've been discharged.
Okay,
Can I make a statement towards this?
Mhm.
sure.
Just the fact of why we brought Margaret on board and why we have her focusing on mental health screens. I know nurses out there are so over screens, and everything we look at, somebody's throwing a new screen at you. And that's one of the reasons we brought Margaret on is so we're not overburdening those bedside nurses with yet more screens. And these screens that she's doing are really important in the trauma population. If you look at the literature, kids who are involved in an injury, whether it's accidental or non accidental, um, we see that within a year after they can develop PTSD anytime with usually within a year after they're injured. And it's not just the child, it's the family. It could be the sibling that starts showing symptoms. And definitely we've seen it with our families. So, we've always known this to be true, but we've never really had the resources or the ability to really dive into it. And so bringing Margaret and that psychosocial team together under the umbrella of trauma helps us really focus on that so important mental health issue of the broken mind and broken spirit that we haven't fixed in the past.
So we're just amping up our care.
Yeah,
Got it.
we
Um,
do a really great job with a lot of the physical aspects of care, but I think sometimes the psychological aspect of it goes to the background a little bit.
oh, 100%. Yeah, we're excellent at fixing like broken pieces, but
Hmm.
when it comes to the mind and the soul, I'm really glad that we are like enhancing our efforts, and I think it's really important.
Absolutely.
Um, I gotta backtrack a little bit. Jen, I forgot to ask you, before we started talking to Margaret. I guess I was just so excited that she was with us. What was your favorite job? Wait, what's your favorite part of the job?
Oh, it's working with you.
Oh, well, yeah. Well, of course, there is that.
Now, it's really fun for me too. I think just as Liz said, it's when you've identified something that could be better and you're able to kind of think outside the box and be kind of novel and put something in place that not only is helping families, but that the providers and the nurses and everybody who interacts with it is like, wow, this is really good. This is really helpful. So it's not just the things that we're dictating down, saying, do this, change this, do it this way. But it's really when you can come up with something that people are like, oh, that was a good idea.
Yeah.
Uh, kind of fun.
Um, Margaret, so far in your whole 5 weeks, um, excuse me, what's been your favorite part?
My favorite part has been being able to get to know these families really well. Um, and by doing a lot of by helping out with the bedside care and getting to the families through like their bedside nurse. So I had an opportunity to shadow in the PICU for a day to see how the flow of that unit goes, and knowing that I would be there to help with cervical collar changes if they needed it, or as a resource for any like trauma related questions. um, Being able to get to know the family from the bedside nursing perspective in the ICU, even though I've never been an ICU nurse, has been so helpful. And just seeing the whole experience, like from in between the consults to when they're just like in the room by themselves, like still kind of coming over this traumatic event. I think you get a really special relationship with these families. So that's been my favorite.
Now that you spent like a day in the ICU
Mhm.
after years in surgical care, and you're starting to do these like mental health like initiatives with the families, do you think that that type of initiative is better served, like, in surgical care where it's less acute, or do you think it should start in the ICU? I know you're only there for a day,
Mhm.
but you do get a sense of things,
Yeah,
especially when you've been in the hospital for a minute.
yeah. I think it's definitely very patient specific. Um, in the ICU, things are changing on a dime. And there's obviously a lot of critical care stuff going on down there. So if there's time and opportunity for these screens to start, that's great. With this one shadow day I had, the patient was intubated. So I had good opportunity to speak directly just with the family. Their child was comfortable, their child was stable, intubated, yes, but the parents were willing to sit and talk. So that was a really good time to get to know them before their child woke up, came to the floor, and was getting into all sorts of other therapies. So I think it would be great, I think, to start earlier.
Cool. Liz, so you've been how many years have you, been in the hospital?
It'll be 20 in September 2024, so 19.
Okay, so and then how many years have you been with trauma?
And with trauma for 14. So I started
Okay.
as an NP with the trauma service in 2009. So
What's been the most surprising thing, when you started in trauma? Whether you knew it or you didn't, or you're just like, "Wow, I just didn't expect that."
surprising thing in
Yeah,
trauma.
and Margaret, it's coming to you too, so you
Okay.
I
Yeah,
put Liz
you
on
have
the
a minute.
spot,
You have
I
a
know.
minute.
sorry.
I'm gonna sit and think.
Most surprising thing. I think how incredibly resilient kids are. I mean, they'll come into the trauma bay following a two-story fall and they'll have a couple of bruises. And just, I mean, how, and they just have inherent positivity. And it's just how amazing little kids are. So that's definitely been incredibly, incredibly inspiring. You know, with all of our patients.
Um, Jen, did you before you started working with trauma, did you like did you understand the whole surgical side of like there's attendings and fellows and residents and or I get Margaret, did you understand that whole hierarchy of like how people rotate and how long people are here? And do you think that it would be now that you've been with us for a few weeks, do you think that information is helpful for the bedside nurse?
I think it's definitely helpful. It took me a while to understand that process and that rotation. Um, it wasn't like supernatural learning it. I kind of had to dig and ask a lot of questions. Um, but I think knowing the team members, knowing who's primary, like who's the best person to go to with certain questions, is very helpful.
So Jen, can you give us like an overview of surgery on a whole and how they interact with trauma? So like go from like attending to fellow to residents, also like SOD and what does that mean? And why don't you always see the same physician every day or why does it change and go through that a little bit?
Sure. So obviously trauma patients aren't scheduled. So when they come in, the surgeon of record is whoever was the SOD, surgeon of the day. There's a daytime
That's
surgeon.
a
D.
D, not a
Yeah.
B.
Yeah.
It's an SOD.
The daytime surgeon of the day is on for a week, Monday through Friday, and they're 6 a.m. to 3 p.m. So you'll see the same surgeon rounding through a whole week, unless it's a holiday and that just gets all screwy. But um, so if, for instance, if Dr. Bird is SOD, you will see him rounding at 6 a.m. and he will be the on-call surgeon until 3. So if a trauma patient comes in at noon, he would be the surgeon of record. They have a different call schedule for 3 p.m. to 6 a.m. And it's not necessarily the same person all week. It may vary. It may be the same person for a couple days in a row. But so you definitely would have a different attending in the nighttime hours. I don't think people realize that as much because they usually don't round during those times. And so they're not looking for an attending. And then on weekends they do 24, the SOD on the weekends it's a 24-hour call. So whoever's on will be on for 24 hours on Saturday and 24 hours on Sunday. Those are the attendings. We have 2 surgical fellows. Our surgical fellows, they're here Monday through Friday during the day. They spend a good portion of that day in the operating room. And they do some night call a couple times a week. Each of our fellows is on call. When a fellow is not on call at night, a senior resident, PGY4, is on call at night. And usually we have either a fellow or a PGY4 available during the day. Both
And PGY stands for post grad year.
Post grad.
Thank you. I
I
was
was like,
like,
it's post grad year. I was like, because
yeah,
I feel like we say that a lot,
yeah,
especially to our bedside nurses, like, what's a PGY for? And it's like, well, what does PGY stand for? So
yes.
PGY is post grad year.
There you go.
Yeah.
So during the day, if you need a senior resident, you would make a phone call. You will either get one of our fellows or you will get the PGY4. Now, these residents, both are PGY4s and lower, they are all rotating here from other programs. Children's National does not have a general surgery residency because we're pediatric general surgery. We're specialized. So all the residents are in general surgery residency, meaning adult, and they rotate here to get peds experience. We get residents from GW, Hospital Center, St. Agnes, Georgetown, Howard,
Maryland.
University of Mary St. Elizabeth. No,
No.
I don't know why I thought of that.
Walter Reed.
Walter Reed. Yeah. So we get them from a lot of different programs, which is why they're all a little bit different. So that's kind of good to know too, going into how all this works. So senior level, PGY4 and fellows, junior level, it could be a PGY1, 2, or 3. And sometimes they will be in the OR, but usually there is one assigned to surgical care to help manage the day-to-day orders and patient care. At night, there's only one on call, and so this resident is taking surgical call, first call for the whole hospital. And so for those of you who work night shifts, sometimes when you're getting really irritated that surgery's not coming down to the ER fast enough, not responding to the floor quick enough, it's because a lot of times they're kind of on their own. Obviously, the senior will help them, but depending on what's going on, they potentially could be in the operating room if there's a nighttime case. So it definitely can be a busy time for a resident.
And how long do our fellows stay for? Because like you have an attending, they're here. They're
here.
here for it. But how long
Attendings live
is a
here.
fellow with us?
So the fellows, just to really be clear, our fellows have finished their general surgery residency. So in actuality, they could go take their boards and work in an adult hospital as a general surgeon. But instead, they decided to do a 2-year pediatric fellowship. And so when we get a Peds fellow, they're going to have 2 full years. They start August 1st of every year, and they'll stay for 2 years, be done in July, 2 years later. And we refer to them as the junior fellow and the senior fellow. The senior fellow is in their 2nd year. The junior fellow would be in their 1st year.
And then how long are our residents here for?
You want to take that?
Oh yeah, Liz, can you
vary?
can you talk a little bit about the orientation process?
Yeah, absolutely. So, so the rotation can vary. It can be 4 weeks. It could be 2 months. In general, it's about 1 to 2 months for our junior residents. For our 4th years, just about a month. But again, it can be a little bit longer. But let's just say anywhere from about 4 to 6 weeks. So before they start, we have a number of resources that we provide our rotating residents. So it includes instructions on downloading the Trauma app. Jen has made a special tab just for resident orientation. So those are key things to know before they start the rotation and important to review throughout. We also give them the directions for downloading Easy TBSA, capture power chart on their phones for photo documentation of wounds and burns. We have a number of PowerPoints that we also send for reference to. So lots of resources are given, again, before the rotation even starts. And then when they start, I feel strongly about going through an in-person orientation where we just talk about the nuances of the care of the pediatric trauma patient. So where do you listen to breath sounds on a pediatric patient? Or how do you examine the belly in a baby that's crying? How do you assess the GCS? And so there are a number of videos that we can refer that the department has made. Again, just figuring out how to teach these things. So again, kind of A to Z, what happens in the trauma bay, where do you need to stand when examining the patient, what's the trauma checklist. So a lot of just, in-person training right there. We also point out physically in the room where the test tubes are, where is the blood fridge, how do you tell how long the patient's been in the room. So so everyone again gets that individualized orientation.
And correct me if I'm wrong, but we have a pretty robust like orientation for our surgical residents as opposed to other places that are taking surgical residents for training. Is that correct? I feel like we do a really good job.
Yeah, I can't really speak to what other institutions do, but I think we get good feedback.
But remember, we're one of the only places they rotate, and when they're at their home institution, they live there.
Right.
So they have.
I guess for other like rotating, like other hospitals that are specialty, like I feel like we do a really good job of like getting people ready to do this job.
We try.
So we have like a whole, and then the one group of people that exist and are like in the hierarchy of care, other than attendings and fellows and residents. I mean, personally, I think the most important people on our team, are us. No, I'm just kidding. Is our nurse practitioner team. I feel like they're the glue. And Margaret, why don't you tell us a little bit about like a bedside nurse's interaction with the NP team?
Sure. Working with the NPs is great. They're accessible. Their office is right on the floor.
And what
doors
floor
open.
are they? What floor are they?
5 East.
Okay.
5 East surgical care.
Okay.
I don't want to suss out their location.
It's
But
another top secret.
exactly. But they are accessible. They're there throughout the day. If there's a couple people working Monday, Tuesday, Friday, somebody will be in the burn clinic, which is over on 4 Main. Um, and then you'll have an inpatient who's there on 5 East. Um, and they've been nurses. They know the flow. They know how over screens nurses are. They get everything from A to Z. So it's great to have a caregiving partner who completely understands the flow and what is feasible, what's not, where people might need extra hands. They're always there to answer questions or to critically think through something, to come talk to families with you. Uh, they're just very like visible and very involved. I love working with nurse practitioners. They stick around, so it's like a familiar face.
I think
Yeah,
they're also a great
they're not.
liaison for the residents training
Mhm.
also. We really point the residents that anytime you have questions, the nurse practitioners, they live here. They understand the system, they understand the patient population, they have all the experience in the world on these patients, and they're really your kind of your go-to.
Yeah, and they're just good. They're just good at
Yeah,
what they
they've
do.
seen everything and they're good.
Yeah. So in wrapping up today, Margaret, what would be the take home um point that you would want any bedside nurse listening or watching to the listening or watching this to get?
I'd say there's a lot of people on the trauma team. Everybody is approachable, and I feel like everybody is willing to help the best way they know how. So if there's ever a question, ever any doubt, feel comfortable to reach out to anybody. I will help be your resource, and if there's nobody else you can come to, feel free to come to me, and I can point you in the right direction. Um, yeah, we just want to help.
And Jen?
Well, I'm actually going to plug Margaret's position because it's a new position that we are, it's still being figured out. But there are key things that she's really looking at. She's really working with us with C collars to try to decrease incidence of skin breakdown. She is working with the mental health team, trauma mental health team, on doing screens and making sure the right kids are getting the referrals that they need. But she also is a nice liaison to, like she said, figure out if you have questions, whether if she doesn't know the answer, she can work to find you the answer, or be there as another set of hands. And I guess the other thing is kind of be patient with us as we're figuring out Margaret's role. I think it'll just continue to get better and better. So coming soon, who knows what she's going to be able to help you with.
And we'll take suggestions.
And Liz?
Well, I think again, just how important psychosocial support is for these families following injuries. Their worlds are really turned upside down. So again, we have a glimpse of what they're going through while they're in the hospital, but there's a whole lot of recovery that happens once they leave. So there's definitely lots of attention that has been paid to it and will be paid to it in the future with this team.
And I guess lastly, in wrapping up, I just would want everyone to know that trauma is more of a team than I think anybody ever really realizes. And you have a bunch of people that are doing a lot of work behind the scenes and in the scenes, to make this the best department that we possibly can, and to provide the best care for our patients. So if you have questions, please reach out. Like, we are always open and available to answer questions and do things to make not only the care of the patient better, but also like, we want to be there for you as a resource as well. So we want to make sure that everybody is set up to succeed, and nobody feels like they're out on a limb trying to take care of an injured kid and be like, I don't even know like who to call. Like, we now you know who to call and a little bit of the hierarchy. So thank you so much for joining us today, and we will see you in a little bit.